Hello, everyone. Welcome to another episode of the Life of Flow podcast. And today we have a banger. We have Dr. Mariano Palena, international vascular man of mystery, globetrotting around the world, curing PAD. And this is number one of our revamped CaseCast series, where Mariano is going to bring us some of his most extreme cases and teach us a little bit about vascular surgery for us, the mere mortals. So hope you guys enjoy. Vamos.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
So we're bringing it back. The CaseCast is back, and we have a rock star joining us, Dr. Mariano Palena, and he is going to be the main show here, bringing us extreme cases from his globe-trotting adventures around the world with CLTI. So welcome, Mariano.
Thanks, Lucas. Thanks, Miguel, for the kind invitation. As always, it's my pleasure to be here and to participate with the both of you in this, let's say, first step, I hope, of many others of case presentations and interaction.
Love it. So yeah. Let's go.
Let's go, Mariano. Show us what you got.
For those of you who are just listening to us, there's huge advantage for today's show that you sit down at some point and look at it, because there's going to be a lot of images. Don't kill yourself driving and trying to watch this.
Yeah. Unless you have self-drive, and then maybe. No, don't. No, that is a joke. That's a joke. Don't die.
Allegedly, people do that.
Allegedly, they do that when they drive to West Texas to do cases in OBO. But all right, Mariano, what do you have here?
So I choose this case because I used to show it to be disruptive and to create and stimulate discussion. And because if we are thinking about a way of case sharing and discussion and education, I think is, let's say, useful and interesting to show what we have been doing. So this is a case I did more than 10 years ago. As you can see, it's a 72 years old male with diabetes, dyslipidemia, ischemic heart disease, with previous CABG, bilateral critical limb ischemia. In fact, you can see the left side already amputated by transmetatarsal amputation, well healed. And the patient arrived to our care many years ago with what you can see there. So, indication for major amputation related to a previous attempt for surgical revascularization by distal bypass on the right leg. And you can see the condition of the right foot. So it's not the worst situation, clearly. It's gangrene of the first with the big plantar involvement, gangrene of the fifth, again with the plantar involvement. So it seems to be not the worst scenario, no phlegmon, nor acute deep infection. But even though the patient arrived with this indication by our friends and colleagues from another hospital and send the patient to us, say, please cut the leg because the patient cannot be revascularized. And to be honest with you guys,
can we stay in the previous image, Mariano? I'd like to yeah. Miguel, yes. What do you see, Miguel? When your expert eyes look at this, what do you see?
Yeah, I mean, obviously, this does fall within this Rutherford 6 category. My mind goes immediately to try to further describe it. Again, for those folks that are not looking at the screen, pretty extensive forefoot gangrene that probably falls within WIfI class 2, class 3. There's a shot that with a transmetatarsal.
Why do you say class 2, class 3?
Because the difference is, can you get away with a TMA?
Mm-hmm.
So if you can get away with a TMA, it's essentially a W2. And then, so W2, remember, WIfI is going to be the combo of the three variables. The I for ischemia in this particular case is 3, which is extensive ischemia, is very ischemic. Mm-hmm. And the foot infection I don't know if there was a systemic effect or not, but it looks like there's some infection. So at least maybe a class 2, maybe local infection. But that altogether, that combination of W2, I3, and FI1 or 2 already puts you at a high stage. So stage 4 aggregated. Stage 4, based on global guidelines, means that there is a high risk of limb loss and that there is also a high potential benefit of intervention. Whatever that intervention may be, to attempt to improve the blood flow, to then go on to the next stage. With this sort of the wound also in my mind when I'm looking at this, again, it's just so important to think what the reconstruction is going to be, because in a way, I'm thinking if this reconstruction is something that I can get healed within 3 months, then potentially some very complex multi-level endovascular approach may be really good if the surgical approach has been exhausted, especially because I doubt that multi-level complex endo is going to have very long patency. At the same time, I'm also thinking when I'm talking to this patient, listen, I want to prepare you that there's a good chance that if we are successful, that you understand, because this is one of the things that most patients I feel don't understand, is you're not going to get cured. Like you're not going to be in remission. I'm sorry, you're going to be in a remission state, but you're not cured, which means that whatever it is that I end up doing, there's a good chance that we're going to be back here doing some, I call it maintenance, touch up maintenance, where I'm going to possibly have to go in maybe once or twice in a year to try to get you past the finish line. And then we can see how much we can back off of the intervention pathway. But that's kind of what I'm thinking when I'm looking at this case.
Two things about that, Miguel. First, obviously, to me, I immediately go to, okay, what's the foot reconstruction going to be like, and is any of that, sole, the plantar aspect of that foot, is any of that going to come back, or is that at the level it's probably going to demarcate, which is what, in my experience, what it would be. So I'm already thinking like this is going to be a difficult reconstruction. Not everyone is as lucky as you to have an excellent podiatrist as your neighbor at Hope. So I'm thinking, okay, I'm going to probably have to take care of this reconstruction myself. The other thing I think is very interesting is the touch-up commentary that you did. Do you think that's kosher in the vascular community to say, hey, you're going to need multiple interventions? Because the bypass only people, let's call them bypass first, would say you just do a bypass, that's it. That's why bypass is great. What's your comment to that?
I think anybody that says bypass is one and done is full of shit, because I've had to do multiple interventions for bypasses to keep them open. And I've had also multiple bypasses that go down and never come back. And it's really hard to reopen a vein bypass once it's occluded. On the other hand, I don't think it's unethical or immoral to give the patient a realistic expectation of the need for primary assisted patency and or secondary patency. I mean, I can tell you off the top of my head 2 or 3 people that I've probably in the last 4 years at Hope have to do anywhere from 5 to 6 interventions. And every time I'm going to do anything, I'm like, listen, we could do a major amputation or we can do an intervention like we did last time. And literally they look at me like I'm dumb. Like, why would you say that? No. Right? Because why would you say that, doctor? Yeah. Like, last time you went through the ankle, it took you 20 minutes and you sent me home. And now you're telling me that we could do that again or you can cut my leg. That sounds pretty barbaric. And I said, yeah, but in a way I need to say it because I know that there are people out there that would hang me on a cross for doing this. And so it's sad that we're in that state of mind. But do you sell that concept, Mariano, to your patients that this is an ongoing disease and that there's a good chance that you may have to at some point do interventions and re-interventions?
Yeah, I think during the analysis, you both guys introduced many super interesting topics. Specifically about the bypass, it is still an opportunity, but look in the tail. The patient did a cabbage, so we don't know if he has veins. I think that the best detail you analyzed, Miguel, was the WIfI. This is not an emergency that need a major amputation, but even though the vascular surgeons sent him saying cut the leg, it's a patient that could have a good chance related to the baseline clinical condition to finish with a TMA if the flow can be in some way improved. About the remission, this is a concept that we have been describing for the last 10, 15 years, and it's still very difficult to explain. The patient cannot have chance to be healed, cannot have chance to pass through this disease. The vessels are diseased and remain diseased. That's the reason why when the patient doesn't need interventions and is healed without use or without symptoms, we speak about remission. And this is a very important concept that we must to clearly explain to the patient. You could even need 2, 3 interventions in a year, but it's a balance between maintain the limb and repeat the interventions or be amputated. I think 99.9% of the patients prefer to repeat the amputation. And again, through this way of cases presentation, we will have chances to analyze many of these that even repeat 2, 3 interventions in the year, but are still walking. Next slide is very interesting. The patient arrived saying, look, we did an attempt to surgical revascularization, and they already did. You can see they review the pop, they review the anterior tibial, they review the posterior tibial, and they even review, they did open access of common plantar. So again, you did your best. Maybe you're a vascular surgeon without endovascular skills. So you have been looking at extreme vascular surgical revascularization by bypass. No angio, for sure, no angio. Or we will see during the way the angio that I did, and you will realize why. In any way, if there is no option for vascular surgery, and let's try to imagine that the vascular surgeons that were taking care of this patient were super good and skilled guys for distal, even for distal bypasses. So they don't find out a landing zoom, a distal landing zoom for anastomosis. So why you offer the patient a major amputation? Why?
Yeah.
So you don't think they did an angiogram before the attempted the bypass?
You can see this is the patient before I start my intervention, because the only good thing for the patient was that the patient arrived to our clinic where there is no amputation without an angiography and without an attempt for revascularization. So when the patient arrived with this clear indication for major amputation, for below the knee amputation, the foot surgeon, our podiatrist that time, decided to send the patient to the cath lab, and we did an angio.
Yeah. I mean, I would be surprised if they did an angio before all these surgical attempts. I'm sure they had at least some images to say, okay, here's where we're going to connect our bypasses to. But I also understand the surgeon's referral, right? In the sense of, I think this patient needs an amputation, right? Because they essentially cut down everywhere trying to connect this bypass. And you know, I've been there. I don't know, Lucas, if you've ever gone to surgery with a very, you know, we always say in surgery you want to have plan A, B, and C, and you cut down thinking this is going to be the perfect vessel, and it's horrible. And so you got the patient there, they're filleted open, you have the proximal artery exposed. So then you're like, okay, well, I got to do another cut down. I'm going to go for the peroneal, and if that doesn't work, then I'm going to go for the anterior tibial. And if that doesn't work, which is really, really sad, you do exactly what this guy did, which is you close the patient up after nothing. And so you just did major surgery, general anesthesia, and then close the patient with nothing. So it reminds me of the time that Lucas and I did this together.
Yeah.
We thought we were doing a bypass to the posterior tibial artery.
No, we thought we were doing a bypass to the peroneal. and then we hit the peroneal, and there was nothing there as a cord.
And we ended up connecting it to a vein. And that was our first arterialization. That was like 10 years ago.
Yeah, but again, following your analysis, guys, let's say they have an idea, but probably they didn't have images. Because if you have a CT scan and everything is occluded, or if you have an angio and everything is occluded, you could review it thinking about hibernated vessel and so on. But you cannot cut down all the leg to try to find out a place to do this anastomosis. And even though after all these things, you can't advise the patient for major amputation.
Yeah,
I understand now what I understand the sense of saying there probably wasn't any imaging because, and I guess this is coming from the fact that we don't know what it's going to look like. That when you show us that, we're going to say, who decided to do a bypass? Because there's no bypassable artery. So why did they cut down on this person like this? This is a very actually good, because I have met this in the past. I've had even mentors that I remember that would book a patient when the angiogram was negative. And I was always very baffled by that. I said,
by negative,
meaning there's no target, but we're going to go explore and see if we find it.
Yeah.
Well, but
and I'm saying,
I should show you the angios.
Let's see the angiogram.
So.
Let's look at the angiogram.
Because this is interesting.
All right. Cool. All right. Look, so there's kind of a.
So what, Mariano, if you don't mind, for those listening, describe this angiogram findings.
Absolutely. This is a 6 French short sheath antegrade in the common femoral. This is CO2 angio by angiodroid devices. Injector. This is profunda with some collaterals. This is SFA, and this is common femoral part of external iliac. So you can see that the inflow is guaranteed. It's nice. So why not to even do a super selective angio to see if you have something? We can have, we can see also a distal SFA and pop with some plaques in the P2. You can see here the knee joint. So P2 and P3, some stenosis, maybe 50-60%, but even so patent. And we can here see the gas already passed, but we can see the gas in the P3 segment, the ostium of anterior tibial, and nothing else. A very teeny tippy trunk, stenotic, and something that seems to mimic posterior tibial, but mostly seems a collateral. So for this angio, I'm not a vascular surgeon, but I don't think that you need to cut down the anterior tibial loads up, because for sure you don't have any chance to make a bypass there.
And Mariano, just for me to understand, is that pop, like is that second segment of the pop a CTO, or it's just that the gas crossed it already?
The gas already passed here.
So that was patent with the stenosis.
Oh, that's patent. Okay. Interesting.
Exactly. Look, you can see this segment here. This is the knee joint. So this is P2, this is P3, and you can see the distal part of P3 before the bifurcation here. All this segment is patent. The stenosis are in this part where we have some plaques of calcium. Sorry for this, but there was a bit delay. But the fem-pop segment is functioning well. There is only one stenosis here in P2 segment. So
well, that also makes me question, to your point, what the fuck was the surgeon thinking? Like, what is a pop to AT with an AT occlusion going to help you with? That's
being
just
not
doesn't make sense.
This was my answer.
That makes sense.
They had an ultrasound and they went by the ultrasound. That's what
probably. Probably they had between ultrasound and CT scan, and they were believing
CTA.
They could exactly that they could find out some hibernated lumen. Anyway, I can imagine.
And also, I kind of want to state that I don't like shitting on other physicians. So this is not that. This is just.
I love shitting on other physicians.
I don't like that. This is constructive, fun discussion of a case. We appreciate every single physician that touches and refers a patient. So we are doing this in the spirit of knowing and education. So I just want to make that very clear.
Yeah,
And the
absolutely.
politically correct prize of the day goes to Lucas Ferrer. Such a good guy.
No, this
Such
is
a
true.
good
This
guy.
is true. This is true.
Come on,
We're,
if we succeed, the idea is to share with the idea to be constructive and positive and even to create
Exactly.
awareness. So if in any way
Yeah.
we can arrive to some colleagues before to set the patient for a major amputation, refer the patient to a dedicated center. If you're a patient and you were advised for major amputation before to do or to allow someone to do to you a major amputation, go to a referred center to save limbs. So that's
For
the
sure.
topic of the discussion. I can imagine that the surgery or this incision was looking for an inflow or proximal anastomosis.
Yeah, 100%. Yeah.
Yeah, clearly. But we can see all the incisions done, and yeah, as typical, we must show the foot angel.
Mhm.
That this was the foot angel. And there is an interesting detail here. First thing, because there is a small movement, and this is an engine with CO2. I know that for many of us, it can be maybe not dedicated contrast agent for food. Believe me, it is. It is. I have a very big experience, more than 15 years, setting up the angiographic machines and using it in many different countries, in many different cath labs. If we set up properly, we can obtain fantastic image. And the right thing is that the contrast was arriving to what we have or we had. So small movement, but in any way, desert foot. So now we can understand two important things. They cut it up a posterior tibial. They find out nothing because there was nothing. They cut it the common plantar, and they probably find out nothing because what do you think? What is happening there, guys?
It's coming from the peroneal. Huh?
Exactly. We are in front of an anatomical variation.
Yep.
So even if some part of the artery was patterned, was following different way, and they were not able to understand it. So the message again is we need an angio before to decide to cut a leg. We can do a super selective angio, and we need to. That's the reason why I said go to a dedicated center, because we must understand what we are seeing, what we are facing. If the anatomy is different for variations, for anything else, and you are not able to understand it, again, the failure rate is so high. So we need to be more dedicated and more precise before to say this is a case because I cut anterior, pop, posterior, common plantar, and I didn't find out a way to do that, to do an anastomosis as a patient with indication for major amputation.
Yeah. So, Mariano, with your experience, because to be honest, I don't have that much experience with CO2. I only use it when patients, have pretty bad CKD, and that's not the most common thing. But I've seen a lot of your presentations, and you use it a lot. What goes through your brain when you see this? Because I don't see anything in the medial lateral plantars. I kind of just see basically what would be a remnant of maybe the distal peroneal and kind of ends above the calcaneus. So I if I saw this, I wouldn't be super hopeful that I can get something done with traditional revasc. But okay, you see that outline there, and that's okay. I see what you're seeing.
There is very, very poor flow. What we can see is this is posterior tibial that find out as a collateral is not a regular posterior tibial, is not main vessel, and its collateral provides flow for the posterior branch of peroneal. So peroneal is fully occluded. Fully occluded. We have this posterior branch very teeny that seems to have some flow in the median plantar, but there is movement, and we don't have a clear image. But in any way, what we need to know is that most of the things, most of the arteries are occluded, no dorsal flow. We cannot see the flow in the arch. What we could expect to have it hibernated or with flow, we don't know. We didn't see flow in the dorsal circulation, neither in the plantar circulation. It's a desert foot, but still we have a chance. We can try. We, at the end, were able to understand why surgery failed, and we were able to understand minimum partially the anatomy. So we know that posterior circulation, plantar circulation is coming from peroneal.
I compared this again. You guys know that I work in an outpatient facility with a C-arm, and we don't have Android. Also, I don't think Android is FDA approved yet. I think that's
No,
a
yet.
project. And so what I do in a case like this is I would probably put a Bernstein 4 French catheter all the way into the pop and literally inject like 1 ml of contrast diluted, which would give you like this sort of very small image. And I say, you're just looking for clues. You're not, when you're putting the puzzle of CLTI together, I see this a lot. And again, I'm not criticizing before you get mad.
You get criticized. No.
But I see cardiologists that inject 20 mLs of contrast into the popliteal to try to get a beautiful image of the diseased foot. For me, that's nonsensical because you still have to do all this therapy. You're going to need contrast through multiple stages of the procedure at some point. There's no sense in trying to get the perfect image at any point in time, by the way. What you need is just some context clues. Okay. And what's the clue here? To Mariano's point, I think he very eloquently puts it on the screen. This is the key to the case. I find that there is a target that has the potential for me to do some work in it. I don't know what the artery looks like. I don't know what the toes are going to look like, but I know that I have a potential, and it's a very good step in the right direction. Eventually, at some point, he will have a microcatheter or a balloon or something in that and can give us a very good image of the foot. But that's not important at this stage. At this stage, you're just trying to understand, is there a way forward? Is there a way that I can possibly get from A to B, knowing that I've got what looks like a sliver of hope? And so I think that's the most important take-home part here, which is don't look for a perfect image. Look for a clue that gives you a path to success.
Right.
Yeah. Yeah, absolutely. This is the concept. So the key point of the case, or the first message of the case, is I think I have an option. Most of the time, I think I have an option, but here, clearly, I understood the anatomy. Specifically about CO2, fully agree with you, Miguel. In many cases, we can even manage with a very small dose of contrast medium. But specifically, this case was our standard of care. So the patient is not in chronic renal failure. If you remember the introduction, I didn't talk about that. To allow us to reduce any risk of seeing in these diabetic CLI patients and allow us to save money, guys. Because CO2 is less cost compared to iodium. I don't know how to function. Yeah, I don't know how
really
to function
expensive
around the world.
Really?
Contrast.
It's so expensive.
Really
I didn't know how expensive it was until I had to pay for it.
Yeah. Android, reach out, buddy.
If we use a good contrast, dedicated contrast for diabetics, like WIfI, this is the highest cost of contrast. And compared to CO2, CO2 is much cheaper, and with good software and some, let's say, stupid things that we adapt, like to bend the foot of the patient to avoid movement, like sometimes do a nerve block to avoid pain and movement, we can obtain fantastic images. Fantastic.
Okay.
So not only for clinical benefit, that at the end is the first and the most important thing, and we reduced minimum 50% the use of iodium with angiogram, but even to avoid or to reduce expenses. Okay, I identify what could be a target, and I think I understood the anatomy. So I'm going to pass with the video so you can see everything live. First thing to show you, okay, this is the angio. You can see the gas going down. You can see the pop that was patent and everything, and even the gas arriving. distally with some medium plant. So my strategy there was how much calcium we. I was trying to stop the video. So my strategy was, as always, full below the knee, below the ankle, because fem pop are patent. So I said, I know that my first target is peroneal. How much calcium I have? It's not heavily calcified.
Can you stop it there one sec? That looks like a navicross with some kind of maybe command to me. What can you give us the details of what your favorite toys are?
What I did is something really aggressive, and it's not my workhorse strategy. What I did was long occlusion of peroneal, long occlusion of anterior. I don't know well about the landing zooms, but I need to rescue this foot and this limb. So calcium, not too much calcium. O35 for French Navicross and O35 Terumo half stiff J-tip guide wire. And you can see properly here.
Which Terumo wire, sorry?
It's what we call J-tip Terumo.
J-tip Terumo.
Yeah.
Okay.
It's an angulated. It's something that was created to mostly go subintimal.
Okay.
So you can see Navi O35 and the O35 Terumo half stiff guide wire. Okay. It's a medium stiff with a U or J tip in the way it makes the loop almost always in any anatomy.
Miguel, in the OBL, so you want to cross that long peroneal. What are you using to cross, and how are you crossing?
So I actually learned this from Mariano. I would use a Bernstein catheter, a 4 French, like a Cordis Bernstein catheter. They're really malleable, very soft, which is good and bad. Good because you feel comfortable that it gives you less injury or vessel trauma. Bad because sometimes you don't have the pushability that you do get with the Navicross. Remember, Navicrosses are braided catheters, so they're very strong. What's great is the Bernstein is $25, whereas the Navicross is maybe 4 or 5 times that. So that's the the ups and the downs.
How much is a Navicross in the OBL? Well, I don't know if you can say that. Yeah.
No, I can't tell you because I'm bound by a particular price point and those contracts.
I'm gonna say probably in Europe, Navicross or 35 is 150, 130.
Yeah, that's what I've heard.
Yeah, sounds about right. Yeah, ballpark. And so what I would do is I would start with that, and then if I don't have, if I'm not getting where I want to. Probably in this scenario, I would pull a Navi, but I usually like to take an 018 Navicross, like a 90 or a 135 that I usually telescope through the Bernstein. And then I like to use wires. I'm a huge Asahi fan. That's one of the things that I've changed in the last maybe 2 years. And I would take something like a Mongo, 014 Mongo wire to try to see how it behaves in the CTO.
Yeah. In the hospital, I would use an 035 Navi with an 014 Glide Advantage. And in the OBL, I would use a 2x40 balloon. I've been using Brosmed balloons and like a command or something.
Yeah, I said this is not my workhorse strategy, so I will stop the video next time. The data, this video is from 2014, so 12 years ago. Actually, we still have this Navicross that, as Miguel mentioned, is fantastic. But if I should do the same case today, probably I will start, as Miguel mentioned, with a 4 French Bernstein Type 2 catheter and combination of all 18 guide wires. I start to do a fantastic experience with the Asahi guide wires 014 and 018 specifically. Well, they have a big family, but the Gladius one, I love the Gladius 014 and Gladius 018 because I have a very good feedback and feeling with this guide wire to work with the tip and to make the loop and go a bit in a good way in subintimal space. Also, like today, the advantage track from Terumo, 018 and 014. So probably my start of this procedure nowadays should be or will be with the forefront Bernstein type 2 and with the Gladius 018 that wire. Trying to, in any way, go relatively fast and aggressive because, well, the target here, I'm going to continue, see if you agree.
Yep.
The target here is to understand if we have something in the foot. So look, Navi, no pushing a lot the wire, but just pushing the catheter with the wire. Trying to control this loop, it means to don't work with the super hard part of the wire, just using as much as possible the tip. You can see always the ear tip, and you can see full recanalization in 2 minutes of peroneal. Check clearly in a vascular structure, but not re-enter. So trying to oblige the guide wire to go in the posterior branch. And finally, I succeed. You can see the navi and the common plantar. So confirming the anatomy and entering in the foot. And now the good and interesting things. Look, this is the median plantar. This is clearly the median plantar. And as I said, it was patent. So let's see the behavior of the wire. The wire was navigating there. The wire was a small navigating with the tip. So clearly we have a target there. We're re-entering the median plantar. I didn't, I avoid to do a check because it was not my target. And from this picture, the good thing that we can see is that the SAD MAC, the MAC of this foot is very low. So we don't have these aggressive calcifications that could put us to start to think how we could manage it, how we could cross, how we could treat, what about multiple treatments. So no calcium. So my strategy, even below.
So if you had a high MAC, what would change of what you did or what you're planning to do?
Well, the idea with the high MAC, high grade of MAC, is to try to stay in the luminal because the subintimal function pretty well even in FEMPOP, heavily calcified FEMPOP. But in tibials, it's more difficult to dissect it and to create a lumen, and in the foot arteries, it's almost impossible when you have calcium.
So when you started your recanalization, you knew that you had a low MAC, so that you were more aggressive with that loop because of that. Okay,
Absolutely.
That's interesting. Yeah.
For me, no calcium is in high percentage a big synonym of subintimal and fast crossing.
Okay.
In fact, no high grade of MAC, so the recanalization strategy didn't change. Just turn the tip of the catheter to go in the lateral plantar, and again, small loop, and look now, this is the tip, more delicate, and the wire maintain this small loop and start to navigate.
Was that still the 035 or was that a different wire?
Still the 035.
Wow.
Look,
okay. Yeah.
The 035 start to navigate, re-enter, we remove it, we check, and we really find out what was really hibernated. The lateral plantar was occluded till here. We can see the clearly re-enter, some stenosis in the junction between the lateral plantar and the arch, but the fifth metatarsal, the fourth metatarsal, and an arch that still seems to communicate to the dorsal circulation.
Yeah.
Just to reinforce the comment before, which is you would have never really imaged this, and B, it would have never really changed anything to get a perfect arch view when you're with all this CTO. Because if you're never able to get all the way down, then who cares? So again, don't expect these preoperative planning angios to be perfect. You're just looking for hints along the way, breadcrumbs, right? You're following somebody that's leaving breadcrumbs, and those breadcrumbs are what you have to take. That's all you got to work with. But now you have a little bit more hope. I'm guessing if you see this, you're like, okay, well, we got something to work with, right?
Now I have a lot of hope because
Yeah.
I have
Yeah.
a distal distribution system, so I
Correct.
know I can make it function. And the biggest hope is for the patient because I know really now that this patient can save completely the limb and can be back walking with just a transmetatarsal amputation.
Would you feel, let me ask you both this, because this is something I would do at this point, is I would give it a little bit of nitro, maybe a little verapamil, because they
Yeah,
seem very small. Do you do this as a routine at this stage early on, or no?
no
Just towards
routinely,
the
no
end?
routinely.
Okay.
If you ask me specifically, I think those arteries are patent but diseased. So
Hmm.
my strategy
Okay.
there is to dilate everything, to
Okay.
dilate even the arch, because for what I can see, the arch is diseased. It's very small, very teeny.
Must use it more at the end because I think that at this point I'm putting on a 1-4 wire through the arch, going up, and I'm thinking of doing 2 vessels. I'm thinking of the AT because I think there's a whisper of a DP somewhere. So at this point, I'm not thinking about that, Miguel. I'm thinking about, okay, like what is the big picture? And the big picture for me here is I'm going to try to open the peroneal and maybe even the AT.
Let's get back to that later, but I would like
Yeah.
to push back on the necessity of a double vessel because
I know
I
you
think
would.
there's a.
That's why I said it. I know you would.
I think, guys, that I think that this case is fantastic to discuss almost
Yeah.
all these concepts.
everything, yeah.
So as you said, Lucas, yeah, what I did was to shift for an 014 wire and to navigate. Let's see which wire it was. It was a Terumo Advantage, no track. You can see that the wire passed suddenly, without problems, entering the arch. We start to do the pre-dilatation with the 2 millimeter short and finally 2.5. We were able to go around and to enter in the dorsalis pedis. So what we decide to do? Till now, the procedure was using no more than 20 minutes. Strategically, the subintimal recanalization of peroneal with a good re-entry in the foot was good because allow us to do this recanalization to pre-dilate this vessel and to re-enter in the foot and to go around the arch. And we already improved the dorsalis pedis because we were able to pass through with the guide wire. So same Navicross and same O35 guide wire. So till now, one catheter, one O35 guide wire, and one O14 guide wire, and 2 balloons, 4 devices. Same catheter and same O13, we approach anterior tibial. Why? Because for transmetatarsal, it's better to have also dorsal circulation because the strategy seems to be successfully because we already have the devices and because we were super fast. And we don't need anything else more. You can see the retrograde wire in the distal anterior tibial, the L35 just re-entering in the distal anterior tibial. We put another O14 and with this is 5 devices and 3 millimeters balloon and this was the result. So if you want to focus more in some other technique and we show the result later, or as you want, I can arrive to the end and we discuss everything finally.
Well, I think there's a little hot topic that Miguel and I get to rant about, which is why not go for the AT? I'll tell you my rationale. You tell me you're gonna tell me why I'm wrong.
Okay.
So the perineal was super fast, first of all. So you have plenty of time on the time clock. Also, the perineal was subintimal and it was long segment. So I like to think in probabilities, and you have a huge wound. You're going to have a huge transmetatarsal wound. So if you're thinking about probabilities, the chances are that that long recanalization might not be enough to give you enough time to heal. So why not increase the probabilities by 2 by doing another one? And hopefully you will have longevity, not amount, but maybe more longevity because you have twice the chance because you have 2 arteries of perfusing that foot while that wound is healing. But that is where my thought process goes to.
Okay.
Yeah. I mean, I would say in your very beautiful and eloquent sentence, you said the probability of this happening, which is a constructed sentence with no data.
Mhm.
And then you said, hopefully, which is also just you wishing it. So
Yeah. We
if
live
I
in an
can give
imperfect
you,
world.
I understand. But then my
Yeah.
refutal or my rebuttal
Yeah.
to that would be that until you can remove the word hopeful and give me a very clear evidence that there is a massive advantage of 2-vessel versus a good 1-vessel outflow, I'm always going to come back to you and say, I don't care if it takes you 1 more minute. It's 1 more minute of fluoroscopy for you and for the team. And potentially a little bit more contrast. And again, I mean, I know when when you see Mariano, it's like a fucking bulldozer, right? Going through all that, and then the angio looks perfect, right?
Yeah.
But you think that we're giving here direction to people that maybe don't have that amount of experience. And I would hate for somebody to be in the OR because you've seen this. You've been there. 6 hours trying to do a revascularization. But this happens.
Yeah.
And so for me, when I think of all these things, I'm like, okay, I don't have enough data to be like categorically supportive of the 2-vessel. And I know this is going to take the average Joe double, triple, quadruple the time of contrast and radiation. I say my thought is more protective is if you get 1 vessel, I would put an IVUS. I would make sure that 1 vessel looks perfect. If I have to spot stent or do a atherectomy or whatever to make it look perfect, I confirm it with ultrasound that I have a PAT that looks good. And I leave the anterior tibial for another day because there's a good chance that this patient is going to come back and is going to need more. And I want to leave my options open as much as possible. Again, nobody's right, but this is just the way that I think about this.
That's a great point, and I think that's super valid. You could leave this because the chances are you come back to do a repeat intervention in the healing journey of that TMA. And at that point, maybe it's just a spot intervention, and then you have the time and the bandwidth to do the AT if you feel like you need to. But take the factor that it might restenose or reocclude. Say that it stays open for however long it's needed. For a big TMA like this, is there a benefit to having the AT and the DP if they're both perfect? Say that the peroneal. Say that peroneal is perfect, that plantar is perfect, is perfusing. Even in spite of that, is there a benefit for that DP?
I think so.
Yeah, I think so too.
I think so.
In fact, guys, as Miguel said, nobody's right, nobody's wrong. Honestly, most of these cases didn't finish with 1 minute more. We know perfectly. Didn't finish with the same devices that we have because at the end you must to add some new balloon because the previous one. So it's more device consuming. It's more time consuming, radiation consuming, and jodium consuming. So we must do this if we need it. No data, no robust data to prove that endoluminal subintimal can have different patency. Here we are in front of a very long CTOs. So we know that the result during the time are going to be not the best. But what we will discuss is which is the project for this foot. So what we need to do, how we are going to do that, and what are our expectations in terms of reconstruction. Because if we are going to do, as you said, extension or deep transmetatarsal amputation, maybe if we can have a good plantar flap, this is the main topic. But we need to attach this plantar flap to the dorsal skin. So if we have both situations, from what I know, and Miguel surely is more practical than me in foot surgeries, as you, Lucas. But from what I know, for transmetatarsal, if you are able to have both perfusions, is always better compared to only one. But in any way, the discussion, no right, no wrong, it depends on the project. Look, we dilate everything, good diameters, 2.5 in the foot, 3 for tibials, and this was the result.
This is what's crazy.
Look the foot. Look the
that's
foot.
insane.
That's crazy.
That's
crazy.
How many collaterals? The medial plant, the
that's
dorsal artery,
crazy.
Yeah.
and excellent perfusion. So dedicated
That's
picture, so no moving. What difference between a dedicated center for limb salvage and just very good vascular surgeons trying to make a distal bypass? Because
Yeah.
I don't pretend to
Well,
critique the colleagues, just the
yeah.
difference
No, we can critique. But is there any world where a say you could have like say that medial plantar was coming from the PT and you put a greater saphenous vein on it. Is there any world where that is better than this? I would say no.
I would have a hard time arguing it.
Yeah,
I don't
But
want to be critic, but I would say no too. This
I would say
medial
no.
plantar is very
Yeah.
tiny compared to the 2.5 of that I finally dilate the lateral plantar, and I don't think that a bypass, a good vein bypass in this median plantar can create this perfusion for the forefoot
I agree.
compared to this complete below the knee and below the ankle revascularization.
and
I don't.
when I say that, I don't say it. I think I'm emotionally biased by it.
We all are.
Because if we are strictly data and being intellectually honest, we would have to say that the data does support single vessel saphenous vein bypass to the posterior tibial as the holy grail, right? At least that's what the best CLI states, and then
We've all participated in trials, and we all know how flawed they are.
Yeah,
That's my comment on that.
I'm saying it just that's what I was trying to say. Is I'm saying it as a personal, as an operator, man.
Yeah.
Like putting a patient into the hospital, putting a patient through a big surgery, the blood loss, the postoperative, the recovery, the 6 hours that I'm going to be crooked on top of the table with neck pain and shoulder pain, the biomechanics of that. That's what I'm saying. Like I there's again no right or wrong, and if anything, the data supports single vessel GSB bypass. But in my world, there's no way that the answer for me is that's better than to offer this 20-minute procedure on a patient that's, by the way, gonna go. Well, this one ain't gonna go home, but could very easily walk out of the hospital that same day and go home. You know, but
In fact, I am fully agree with you. We have robust data that allow us to think that the single vessel bypass runoff is fantastic. But this patient had the opportunity, and again,
yeah,
skilled vascular surgeons were
Yeah.
not able to make it.
Yeah.
So if you fail, I don't believe you are stupid. I believe you are a skilled colleague trying to save the limb. But if you fail, and I can do that, why you refer the patient for major amputation? You should refer the patient in a dedicated center for limb salvage to have at least a second opinion. Okay, this
Yeah.
is what I like. I would like to focus more. No critics, but if I'm not able to pass re-enter and so on, and there is a chance for a bypass, I never send the patient to an amputation. I send the patient to do a bypass.
Mariano, do you remember what they did? Do you remember what the podiatrist did with this particular foot wound? It looked like a TMA. Ah,
Beautiful.
look at that.
Look at that.
That's so beautiful.
Chef kiss.
That was completely healed. You can see the data. It was not 10, 10 years ago. As I said, it's 2019. So it's 7 years ago. The patient was fully healed after 3 months. I think. I don't know if I have the longer follow-up. No. This was the last picture, but the patient was fully healed after 3 months. Was with the dedicated shoes. Okay, it passed. It went. Was completely healed. Was back to walk without problems. Dedicated shoes. Entering the secondary prevention system in our limb salvage clinic. And from what I remember, the patient was not treated again.
That's awesome, man.
Awesome.
That's awesome.
Cool.
Beautiful. All right, guys. Well, I think we're coming up to the top of the hour. I want to appreciate Mariano's time. He is in España, in Marbella, and if you know a little bit of what that is, there is 1,000 better things for him to be doing right now than to sit with us and go over cases. So thank you for your time, man. We really appreciate it. And it's such great. Yeah. It's always such a pleasure to see you present and operate, and you offer such a perfect view on this topic that it is always really a pleasure.
Was my pleasure, guys. I enjoyed too much this discussion. I think the future of education event is more or less this. So friendly discussion, no critics, just construction, and feeling very comfortable to say what we really believe and what we really want to do.
Yeah, maybe a little bit of shit talking, but not that much.
No.
All right, guys, this was awesome. We will repeat it. We will do it again. Ciao.
Pura vida.